Welcome to Working Smarter, Concise Compliance Conversations featuring Wendy Rubis, sponsored by VillageMD, primary care physicians, practice medicine the way you've always wanted, data, resources, and clinical decision support to care for your patients inside and outside the exam room.
Hi, welcome to Working Smarter. I'm Wendy Rubis, General Counsel of VillageMD. I'm so excited to be here today with Prasanga Lokuge. Prasanga is a Director of Product Development. Prasanga, welcome.
Thank you, Wendy.
So today we're talking about ED utilization and in particular avoidable ED visits. We have some data to show what we all sort of know in healthcare, which is that ED utilization is critical to the value-based world. And we've seen over the last several years an increasing trend toward overutilization. A lot of people feel like inappropriate utilization of the ED. So Prasanga, just as a starting point, why don't you tell us, in your view, what is an avoidable ED visit?
Sure. So even before I get to avoidable ED visit, I'd like to address why this is such a challenge and such an issue. In a study that was done in 2017 in the US, it was found that of 24 million visits across 750 hospitals, more than about 4.5 million visits were potentially avoidable.
And we know the cost of that is just
It's
astronomical.
ginormous. It's in the millions.
But
it's in the billions.
It's so important that our language and our thinking around this is avoidable ED, because we do all need the ED. The ED has a place, and we don't want to overcorrect and end up having terrible outcomes.
Absolutely. Yeah. When you think about a loved one, always think about it from the point of view of a loved one. We want to keep a loved one out of the ED in order to save them the traumatic experience of an ED if they don't have to go through that. That's the whole reason we've come up with a methodology for ED avoidance. So what is an avoidable ED visit? There are two definitions for it. One is if a patient sought emergency care when in fact the condition could have been safely and effectively treated in a primary care setting. Or if the patient did require immediate medical attention in the ED, however, the emergent nature of that condition was potentially avoidable or preventable had they received timely and appropriate care at the primary care setting.
So I think that's so important to just start there and say, you could have gone to a primary care, or had you been going to primary care, you wouldn't have gotten that sick.
Exactly.
So I think it's great, and I know that out of product we have a new methodology, which if you're not familiar with these VillageMD methodologies, they are very robust and very evidence-based, series of guidance around things that are important for value-based care. And we like to say the big brains in product that are writing these are just phenomenal. And so what I really like about the work that you've done with the avoidable ED methodology is it's not a blanket one-size-fits-all approach. And you start with the guidance is you have to understand what the circumstances in your practice, in your area, whatever that may be. And to give an example, you did a study, I think, of Kentucky and Chicago.
Correct. Yes. We've actually, since rolling out the methodology, also had a chance to look at data in the other markets. And every market has a different story, but the storyline is the same, which is there's a high percentage of patients who could have been potentially kept out of the ED. In Kentucky, we know that in between November 2017 and November 2018, over a 12-month period, about 2,500 ED visits were recorded among about 1,300 Medicare patients. And of these, about 88% of these visits did not result in an inpatient admission, which means that the patient was treated and released. Of that 88%, about 34% were deemed avoidable. So if you think about the larger picture, there's a very large segment of our patients who may be a high risk or not, who are going to the ED when they could really be getting much more continuity of care if they went to their primary care providers.
I think that's really the point, is that the care is actually better if it's not delivered in the ED. Do you want to just give us a brief description of the core elements of the methodology?
Absolutely. So the methodology that we've put together for ED avoidance is basically a playbook that any market can take on and customize to meet the needs of their own practices. It contains the VillageMD endorsed strategy and approach to keeping patients out of the ED. It also provides an implementation guide for both PHO and care management teams, because ED avoidance really sits at the juxtaposition of those two roles. We also provide a lot of different tools and workflows. There are patient-facing materials like patient letters, patient calling scripts, and also patient posters that you can use to educate patients on appropriate utilization in order to provide the best care for them. So if anyone in the markets or practices is looking to implement an ED avoidance strategy, the best first step would be to go to their PHO lead or their market lead.
Great, thank you. One of the things that happens in my office is I get phone calls, and I've actually had this several times. I think people are using the methodology, which is good, because I've actually got several times the question. People want to educate patients about avoidable ED visits, and they ask me to look at the language. And of course, as you said, in the methodology, there's a sample poster. Sometimes people want to customize and they want to do things. So a couple tips on if you're educating patients, if you're creating material, just to keep in mind. The first thing is we do recommend that you have a purpose statement related to value. So you don't want to say how to save money. You don't want to go too far and say never go to the ED or something like that. You want to describe value, which is usually quality and cost. There's so many different health campaigns, Prasanga, that we're seeing. For example, in women's heart care, they're educating women. Heartburn may seem like heartburn, but actually it's a heart attack, okay? And sepsis care. You know, I've had devastating cases where a scrape on a child's arm has terrible consequences, okay, due to sepsis. And so we always want to remind people to use good judgment and to listen to their own bodies. The goal isn't to tell people that they're foolish to go to the ED. We have to be careful about that. So we do like to recommend good judgment. There are clinical conditions listed on our sample. If you're listing clinical conditions to patients, make sure that a clinician in your practice is approving that list. Again, some of this is good clinical judgment. One of the things I think that's so great about the methodology is you are recommending to practices different things and approaches that they can implement to give people options. And so we always recommend, if you're steering patients to a different option and it's your own, you just want to make sure that's clear. You have a financial interest in what you're recommending, that they understand that. You know, one of the things that we see all the time, I just read a big article in one of the major newspapers just last week, the situation where people are out of network. And so, of course, if you're steering people or recommending and there's network issues, want to just make sure that you're advising them of that and aware of that. Last thing is, each state defines emergencies. And so sometimes people want those state law definitions on there. In general, we're very supportive and excited about this approach. In my experience as a council of hospitals, I think this is such a smart and important strategy, not just for cost, but also for quality, continuity of care. And so we're just trying to make sure that we understand where the risks are with it. So we always, Prasanga, like to end our podcast with key takeaways. And I think what we're expressing is avoidable ED is such an important part of value-based care. We have a methodology. If you're working with VillageMD, talk to your PHO lead about getting it, or if you don't know who that is, send us an email in response to the podcast. We're happy to reach out. Just be mindful of the language you use and unintended consequences when we're talking about avoidable ED. So Prasanga, thank you so much for joining us today.
Thank you, Wendy, for having me.
And we are really excited about this work and hope you'll come back and check in with us another time.
Thank you to our sponsor, VillageMD. We hope you will join us for future concise compliance conversations.